Hi, Saris.
Hi.
I'm Rahul.
We are live.
Hi, Rahul.
We are live? Okay, good. Good evening, postgraduates, and welcome to this 74th episode of All India Postgraduate Teaching Program, an initiative from Academic and Research Committee of All India Ophthalmological Society. We call this PG program a program with difference because we tend to cover here some uncovered aspects of other teaching programs. For example, some case presentations, journal clubs, OSCEs, and didactics are rarely taken, and they too on a topics which are not really comprehensively available for you at a textbook in a go. So here we present our 74th episode of the series, which is going to be a didactic lecture on laser and refractive cataract surgery, which has been a long question in one of the MS finals. And today's didactic lecture will be presented by Dr. Ritika Sachdev, who is a director, Center for Sight Group of Eye Hospitals. I'm really thankful to Dr. Ritika for sparing her valuable time. I know her some cash registers would go down because of this postgraduate program, but thank you. My special thanks also goes to Dr. Rahul Shukla, who is an administrative director of TN Shukla Eye Hospital, Jabalpur, a dear friend of mine. Also, Dr. Jeevan Laidi, who is a director of Dada Laser Eye Institute, Pune, and Dr. Cyrus Mehta, Chief International Eye Center, Mumbai. All these three discussants are very dear friends of mine, and I'm really thankful to them for sparing their valuable evening for our postgraduates. Now, without much ado, can I request our ARC member, Dr. Anagha, to take forward the further proceedings?
Thank you so much, Dr. Prashant, and a very warm welcome to one and all to this AIS ARC webinar PG teaching session. So it is a great honor for me and privilege to ask Dr. Ritika Sachdev ma'am to give her talk on laser and refractive cataract surgeries.
Thank you, Dr. Prashant, Dr. Anaga, and the entire team at ARC for this kind invitation. I would be talking about femto laser cataract surgery and how the predictability that it brings makes cataract surgery akin to a refractive surgery. Before we move forward, let's understand the basics of the femtosecond laser. Since this is a talk for postgraduates, we will be keeping the talk more basic. The femtosecond laser is a near-infrared wavelength laser, which functions at about 1053 nanometers. Femtosecond really means the pulse duration is a few hundred femtoseconds. Femto is 10 raised to the power minus 15. So such a small duration of pulse means that you can deliver high energy pulses over a very short time and therefore create an impact in a small area with minimal collateral damage. This effect is used to create a cutting tool through a femtosecond laser. Do note that the femtosecond laser, for it to be transmitted, needs to move through transparent tissue, and opacity will obstruct the passage of the femtosecond laser. So this is how the femtosecond laser works. We have very tiny, precisely focused spots of the femtosecond laser. There is a term called numerical aperture. Numerical aperture is inversely proportional to the size or the fineness of focus, right? So by using a high numerical aperture, you're able to create precisely focused laser spots. These laser spots of the femtosecond laser work by the principle of photo disruption. A lot of the postgraduates would have heard of photo ablation, which is the excimer laser mechanism of action. The femtosecond laser works by the principle of photo disruption, wherein when the femtosecond laser is precisely focused, it creates plasma from matter. Plasma, when created, expands. There are shock waves that are created, and this plasma then expands to create cavitation bubbles of gas. So these gas bubbles expand and when stacked together will create a cleavage plane. So you have a cleavage plane or a cut that is produced through tissues, be it on the cornea or in the lens, and these cuts are precisely fashioned as per the program that we have put in. So if you stack these cuts horizontally, you get a horizontal cut. Vertically, you get a vertical cut. And these cuts are used for making the femtosecond laser platform do certain steps of the cataract surgery to automate them and make them more predictable. When these steps become more predictable, you're more likely to get a more predictable outcome in terms of the optical outcomes and the lens placement, making femtocataract surgery akin to a refractive procedure. The following steps are what is automated with the femto platform. Very importantly, the capsulorhexis. The femto laser creates a perfectly centered, consistently sized, and predictable capsulorhexis. It also creates fragmentation in the nucleus. When a nucleus is softened or broken into pieces, it becomes easier to phacoemulsify, reducing phaco time and possibly complications such as PCR. Its action on the cornea lends its application to incisions. Remember, when you have to create consistent incisions, your SIA becomes more predictable. So the primary as well as the secondary incisions can be created in a pre-designed fashion. Arcuate incisions, which are cuts into the cornea, can be made to correct mild degrees of astigmatism. So all in all, important steps become more predictable. Arcuate incisions is an important thing for you to know. This is something that has allowed astigmatism correction of mild amounts to be done by the femtosecond laser. In fact, in certain Western countries, the femtosecond laser is approved for correction of mild degrees of astigmatism. Of course, for more significant amounts, toric IOLs are the treatment of choice. Now, the femtosecond laser actually had its inception for cataract surgery in 2009, and it was in 2010 that the US FDA approved the various femtosecond laser platforms. Presently, 5 platforms are quite readily available. We have used the Catalyst platform, which was acquired from Optomedica and presently is distributed by Johnson & Johnson, the Lensex platform by Alcon, the Lens AR platform, the Victus platform from Bausch & Lomb, and there is the Femto Z8 by Zima. All these have some differences, but largely it is using the femtosecond laser platform is using the tiny pulses of energy and connecting to the eye through a docking mechanism, which I will be explaining in due course with the videos. Coming to each of the steps and the advantages they offer, first is the incision, right? So whenever we have to do a phaco procedure, we have to make an incision. Many of you would have possibly started doing phaco, and you know that the incisions, if they are made in a multiplanar mode, they seal better and they give you a more stable outcome. So when you customize the geometry with the femtosecond laser platform, you see you can go uniplanar, biplanar, triplanar. You are getting a better wound architecture and you are getting stable incisions and you are getting a very predictable SIA. Theoretically, all this does make a lot of sense. There are, however, some practical downsides to it. We have a lot of our patients who have dense arcus, and these the femtosecond laser may be a little difficult to have it work through any corneal opacity. Also, because it requires clear tissue, we tend to place the incisions more corneal rather than limbal. And for those of us who prefer limbal incisions, we sometimes don't use the femtosecond laser platform for the incisions and do our limbal incisions with the blade. When it comes to the capsulorhexis, the femtosecond laser platform can size the rhexis perfectly. A consistent rhexis gives you a more predictable effective lens position, which gives you a more predictable refractive outcome. Studies have shown that the rhexis itself, if it is not predictable, can lead to up to a 0.42 diopters of discrepancy in the refractive outcome post-surgery. This is just a depiction that the lens is not only better centered with a consistent CCC, the IOL as well as the rhexis overlap being consistent makes the lens not move and reduces your risk of PCO. So these are all important factors in the long-term outcome. If a lens is centered, particularly in a premium IOL, it gives you a better outcome. Lens tilting can induce, aberrations such as coma. So a perfectly centered lens, better outcome in terms of visual quality and better biometric outcome because of the more predictable, effective lens position. When you look at the centration of the capsulorhexis, this is from the Catalyst, we can center it on the pupil, on the limbus, or on the scanned capsule. We can also custom center it. There are various schools of thought on where to center the capsulorhexis. Centering it on the pupil may not be absolutely ideal because when the pupil dilates, the center may shift. Centering on the limbus is also an option, but the visual axis and the corneal center sometimes is not the same. In fact, often is not the same. Centering on the capsular bag is quite recommended by many surgeons, and therein coming the option of scanned capsule centering, wherein you're centering the rhexis on the capsular bag because the lens naturally tries to center itself as per the capsular bag. So this ensures a good match of the rhexis and the IOL position and a good 360-degree overlap. Coming to the lens fragmentation, the femtosecond laser, by creating small cuts within the nucleus, is able to break the nucleus into pieces, and each of these pieces can further be softened using a grid pattern. When we do a chopping of the nucleus, we are actually creating the segmentation. This femtosecond laser pre-treatment gives you these pre-cut segments and therefore reduces the complexity of chopping as well as reduces the need for phaco energy. When you are using less phaco energy, your outcomes in terms of inflammation the next day, corneal edema the next day, and endothelial loss over a long term are likely to be less. So these are just some of the patterns to show you. Studies have shown that the femtosecond laser pre-treatment reduces the need for phaco power or the CDE by between 33 to 70%. Does this translate into clinically better outcomes? Significantly better outcomes have not been shown if you do routine cataracts. There is no significant difference in even endothelial cell loss that has been reported in many cases, though some cases have shown an advantageous role of the femtolaser platform in a lesser corneal thickness on day 1. That means the corneal edema is less, and in improved endothelial cell count post-femto. However, most studies have not shown a significant difference over the long term. Another application of the femtosecond laser is the use of the laser to create arcuate cuts. These are small curved incisions made in the corneal periphery to reduce astigmatism. So when we do a cataract surgery, we often place the incision on the steep axis. Some of us are more used to doing a temporal incision. So if you're placing the temporal, you then can also do the AK, arcuate keratotomy, on the steep axis. Now, obviously, the longer the curve, the more is the astigmatism correction. There are various normograms that are available, and you can size the cuts as per the amount of astigmatism that you are trying to correct. These cuts are not, they are not full thickness, obviously. They are deep corneal cuts, and we open them on the epithelial surface with an instrument. If you don't open them on the epithelial surface, you don't cause the anterior surface gape, the effect that you induce is less. So what you can do is actually make these cuts and next day post-operatively decide to open them if needed. However, a word of caution is that whenever you're trying to correct large amounts of astigmatism, the AK may not be as suitable because they're not as predictable in higher degrees of astigmatism or as effective. And there is some regression of the effect when you're trying to correct high degrees of astigmatism. So when do we use the arcuate cuts from the femtosecond laser is when we are dealing with astigmatism up to 1.25 diopters in case it is with the rule astigmatism. In against the rule astigmatism, up to 1 diopter is what we are correcting routinely. And for higher degrees, toric IOLs are a more predictable and stable correction for astigmatism. These are the AK cuts. The new Catalyst software upgrade has now given a built-in nomogram where you can make the arcuate cuts. The platform will give you the nomogram for that. In case you're using a toric IOL, you can put radial marks instead of the ink that we use to align the toric IOL. And there are cyclotorsion compensation mechanisms built in. So the alignment of the toric IOL, again, is more consistent. So this is the astigmatism element, which improves the refractive outcome in cataract surgery. Just to show you an illustration of what the graphic user interface will look like, if you're using the Femto platform, you can see the arcuate cuts in case you have to make them. These are tiny arcuate cuts. And you're also able to mark the incision of the axis of the toric IOL or the incision if you want to make the small radial cuts. These are just marking. They will not have an effect on the astigmatism because you're not going to open them on the surface and they're radial in nature. Just showing you a few examples. We often have patients, the true advantage of femto laser platform is seeing its use in complex cases and in fact giving outcomes with premium IOLs. So I'll be showing you each examples and sometimes a combination of both because hard cataracts and complex cases often demand premium IOL options and they should not be deprived of it and they should be given refractive outcomes to their satisfaction. When you are using a femtosecond laser platform, the way to connect it to the patient's eye is to use a patient interface. It's actually a plastic device with a suction tube, which gives you the vacuum that causes it to latch onto the patient's eye. It is also what increases the cost of the procedure because each of this is a disposable one-time use device and comes at a significant fee. Now, once this latches on to the eye, there is a slight increase in IOP, the vacuum that holds the patient's eye in place and connects the laser. The first step is to image the eye. The second step is to overlay the treatment. And the third step is to perform the treatment. The imaging is often done by the integrated OCT, which is integrated in most of the femto platforms. The Lens AR actually doesn't have an OCT. It has a confocal imaging system with the Scheimpflug imaging. So this is the kind of image that you will get once you have docked on. The image will be that of the cornea at the bottom. This is an image of the anterior capsule. You take an image and you kind of unfurl it like a scroll. And this is going to give you the anterior capsule. And then you have the lens with both the anterior and the posterior landmarks of the lens. You then place your treatment. The lines are defining the zone over which the femtosecond laser will act. So when you are doing a capsulorhexis, slight offset is there to basically make sure that you get a continuous capsulorhexis. The pink line that you see above and below the capsule. When you're doing the incision, again, you are going to put the incision landmarks to ensure that you're getting the planes that you need. And when you are doing the nuclear fragmentation, the zone that is marked in yellow in the lens is showing you the area that you will be fragmented. We normally keep a good anterior and posterior default from the anterior and the posterior capsule and fragment the inner core of the nucleus. This is to show you that the patient interface evolved from the earlier one that I showed you, that was the LensX. We now are using the Catalyst, which has a liquid optic interface, which has a lesser suction. And this has certain advantages in improving the quality of the capsulotomy cuts. So this is the liquid optic interface, but essentially the patient interface in any system is to connect the patient to the device. This is the Catalyst system that most of the videos in this presentation will be on. The patient lies here. You have the device, the patient interface that connects the laser head to this, and you have the foot switch, which you press to have the laser fire. The screen that you see is the interface, the graphic user interface display that allows you to see the treatment and how it is positioned on the various landmarks of the patient's eye. The integral guided system also allows you to compensate for the tilt. So there are various intuitive things. So various doctors have actually called this AI-enabled, OCT-guided, robotic. Femtosecond laser has been described with various names. Flax, of course, remains the most consistent. So this is again the tilt compensation so that you're able to give consistent outcomes despite a slight tilt in the patient's eye. Let's go over a surgery. Now, this is the Catalyst platform. You have the patient interface that has to be centered and locked in. Once this is connected onto the patient's eye, the patient just feels a sense of slight pressure. The OCT display now kicks in. The OCT display will have, and the landmark graphic user interface will have the landmarks marked, the limbus, the pupil, and the capsular axis and the cuts that we are making in terms of softening. This is the corneal incision that we are making. I'm just moving it a little anterior because I said sometimes through the arcus, the corneal incision is tough to open. So I'm moving this anterior. This is actually the first femto I did on the Catalyst. This is the side cut. So you see the capsular axis comes in very quickly. Usually the capsular axis is the first in all platforms except the Zima, which does capsular axis after fragmentation. So whenever the femtosecond laser acts, gas bubbles are produced. So you can see these gas bubbles being produced as the nucleus is being fragmented. And now the incisions will come in. The corneal incisions will produce something like an opaque bubble layer that you see in the femto flaps. So again, you have gas being produced within the cornea. The escape of the gas actually indicates that the capsulotomy is free in certain areas. And with the newer software upgrades, the capsulotomy is usually free floating. You see the primary incision has come in, now the secondary incision, right? So when I'm actually going in, this is the first Catalyst case, you see that the Rex is actually floating. It doesn't need any manipulation. It is absolutely a free floating capsular axis. But since it was an early case, we used to take our time to be sure that the Rexus is free floating, because if it's not free floating and you pull it, you risk a capsular tag and a tear of the anterior capsule. Now, this is the visco dissection that I'm doing. There is no chopping required. Since it is a softish cataract, simply going in with a visco is allowing me to split the nucleus into two heminuclei, right? And what you see in the process are these gas bubbles escaping, because the byproduct again of femto is this gas. So there is some degree of gas built up in the capsular bag. So if you really have a lot of gas build up and you do a lot of hydro, sometimes you have a capsular burst in the posterior capsule. This was an initial complication reported when femtosecond laser platforms had started. Now this is increasingly uncommon, but we normally burp the capsule and we don't do a very vigorous hydrodissection because the gas that has been produced has already done a pneumodissection. So this gas has escaped, and you see that when I go in, there's hardly a chopping that is required. Each part can easily be, there is easy purchase and division of each part, and you are able to remove the nucleus very easily. Then the IA is done and the IOL is implanted. Again, moving to a case of a hard cataract. This is a near brown-black cataract. You see that the rexus is free floating. Sometimes the rexus has some tag, so we always pull centrally, okay? Because if you just pull towards the periphery and if it's not fully cut, you will have a rexus, a capsular tear. Now you see that this, when I'm trying to chop, there will be some gas bubble escape. These are difficult nuclei to chop because they're very hard. So it has been pre-cut. That's how the gas is escaping. And that's why the chopping is easier to do even in a very, very thick and bulky and hard nucleus. And you get a through and through chop. Often when you chop a very hard cataract, the crack that you get is incomplete. So because of the additional help of the femto pre-cut, you see that the piece has a good segmentation and you are getting, even in a black cataract, a pizza pie cut out of it, right? For the want of time, I'll just show you that the outcomes are, in terms of the corneal clarity the next day, are better because you've used less phaco energy. Now coming to the white cataract. The white cataract obviously has a challenge of a capsulorhexis, and a good capsulorhexis allows you to place even premium IOLs in a white cataract. We'll just be showing you, this is on the LensX, so you can see that the interface is slightly different. Then you see the burst of the white fluid. Now, such a thing can lead to Argentinian flag sign if you're not doing a femto cataract. But this escape of fluid in a closed chamber allows you to get away without an Argentinian flag sign and often get a good rhexis. Now, remember I mentioned that the femtosecond laser needs a clear media to act on. So sometimes when you have too much of a white fluid escaping, there may be skip areas or areas of non-treatment, like you see here. There was a tiny 20-degree arc which was incomplete. So we stain the capsule. And what has happened here is because of the white cataract the area being opaque, the fragmentation has not happened, right? Because the femto is not able to transverse an opaque media, but white cataracts are often not as hard. This one is, of course, a harder white cataract. So we have to chop without the help of a femto pre-chop. Again, another case of a phacomorphic glaucoma. This patient had a crystal lens in the other eye. Crystal lens is no longer as widely used because we have better lenses available, and didn't have a toric version. So these are arcuates that are being done. Arcuate incision for the removal of the minor degree of mild astigmatism. Again, you see the rhexis. In fact, a crystal lens requires a larger rhexis. So this is one of, again, a very old case, but you see that a consistent rhexis has been done. And therefore, lenses such as the accommodative IOL in this case, of course, we no longer use this as much. But this is just to demonstrate that premium IOLs, which require a consistent central rhexis, can be placed. And if there is mild astigmatism associated, that can also be treated in a predictable way in cases is as complex as phacomorphic glaucomas. Coming to advantages in other cases, such as the posterior polar cataract. Posterior polar cataracts also have advantage in the femtosecond laser platform that the OCT brings in. The OCT allows you to visualize the posterior capsule before entering the eye. This OCT shows a discontinuity in the posterior capsule, so you know you're likely to face a PC gap, right? So you go in, the rhexis is complete. The good rhexis gives you the advantage that if you have a PC rip, you will be able to put a lens in the sulcus and you'll have a good rhexis to support it. Whenever you are chopping the pre-cut nucleus, you have to do less maneuvers. You don't have to do hydro because it is pneumo-delineated. So you are able to, without much rotation and hydro procedures, remove the nucleus, and therefore the risk of a nucleus drop in a posterior polar cataract is nearly negligible. So we finish this case as we would do by removing the epinucleus. There was a large PC defect, which we had seen on the OCT, and therefore a 3-piece IOL is implanted in the sulcus. Various studies, including a paper we've published, have shown the role of the OCT. So the femtosecond laser, not only by the treatment, but also in the diagnostics, helps you being better prepared. This is a case where there is a subluxation. It's a post-traumatic subluxation. Remember, I had mentioned that the capsulorhexis centration is very important. So just to show you that The capsulorhexis in a subluxated case may not be centered on the pupil. Here, you need to center it as per the lens. If the lens is shifted on one side, once you centralize the lens, you want the capsulorhexis to be centered on the lens. And this will give you a good outcome and a better centered lens. Having a capsulorhexis done, because when you're doing a capsulorhexis on your own, you need zonular support to support the rhexis movement, right? And whenever you're chopping, you're putting stress on the zonules. So the ability to do this with pre-treatment with femto allows you to manage complicated cases with greater ease. This is the post-operative outcome of this patient. So after all these cases, I would just like to end by saying that the use of the femtocataract is finding its acceptance by ophthalmologists, particularly in complex cases. There have been 2 large randomized controlled trials which have been done, FACT and FEMCAT, which have compared the femtocataract to conventional phacoemulsifications. They have not shown any significant difference in visual outcomes or cost effectiveness. But remember, these were through a wide range of cases. It is in premium IOLs and complex cases that femtocataract possibly has a greater use. And another fun fact would be that it was actually almost 10 years after phaco came in that randomized controlled trials showed that it is better than the conventional cataract surgery. Endothelial cell loss, like I said, is minimized using the fragmentation, and a more predictable IOL placement does give you a refractive akin outcome by minimizing the 0.42, which is an average value of discrepancy that comes in if you have variations in your rhexis. So with that, I'd like to end the presentation. What I have not covered is just one fact which I think a postgraduate should know, that there are certain contraindications for the femto laser. I had mentioned that the femto laser needs a clear media to act on. So if you have corneal opacity, the femto laser cannot act through the corneal opacity. Corneal opacities may not be large, sometimes even having archaic cuts, which are discrete corneal opacities, may make the femto treatment more tricky. Also, if your pupil is very small, your rhexis will not come up. Of course, you can kind of innovate and put pupil expanding devices before taking the patient on the femto platform. But largely a small pupil is a relative contraindication for a femto laser treatment.
Thank you so much, Dr. Ritika, for an excellent comprehensive presentation on femtocataract. And let's have some discussion. Dr. Jeevan, welcome. You can switch on your video too. Yeah, so Dr. Cyrus, which platform are you using right now for the femto? And Dr. Jeevan, Dr. Rahul.
Naga. Hi, Ritika. I watched the presentation. Really nice. Can you all hear me? Because I'm on
Yes,
my
yes. Yeah,
AirPods. Okay.
yeah.
So I've been using the Catalyst now from 2016. And whenever any new technology comes out, everyone says that the old technology is better. And I watched the evolution of ECC into phaco, and that was right at the forefront of it. And all the same people said that ECC will be better than phaco and no one will do phaco. Of course, we know how that went. And femtosecond laser cataract surgery is here to stay, is definitely better. There's no question about it. Only those who don't have the laser will say that phaco is better. When they buy the laser, then they will say that laser is better.
Right. So we were just discussing about,
Uh,
Dr. Ritika mentioned about.
Hello.
Yes. Hi, Dr. Jeevan.
Yeah,
Hi.
yeah, hi. No, very, very simple question. So, okay, we have a femto laser here, where especially in the cases where it's a hard cataract, hypermeasured cataract, where the space is very minimal. Okay. So, the femto laser is basically a production of air bubbles, and that is what is going to cause the dissection. I just want to ask Dr. Ritika that in a hard cataract or a mature cataract, when you have that division of the nucleus, which is done by the femtolaser procedure, air bubbles are already present between the nucleus and the posterior capsule. How do we do the hydro procedures in these cases? Thank you.
So there are two facts. First, that of course, I think as the technology has improved, the amount of air bubbles we used to see, the distension of the bag has become less. But definitely there are instances where a capsular rupture has been reported if you don't decompress the bag. So the first thing we do is rock it slightly and we see the air bubbles come out. Once the air bubbles have come out, you're fairly sure that the bag has been decompressed to some extent. The hydro that is done in a femto may be done in multiple small squirts instead of one wave. And you often sometimes don't see the wave, but you can be sure that a good pneumodissection is available. So these are the 2 points. Burp the nucleus and don't be very vigorous with your hydro. Smaller, gentle hydro, and knowing that the nucleus is already pneumodelineated is what helps.
Right, absolutely.
Thanks, ma'am. Thank you.
Yeah.
Dr. Rahul, you were saying something? Yeah.
And one more thing, the posterior capsular rupture, the incidence of the rupture, I just went through because the PGs need to know about this. It's around 0.5 to 1.9%. Now, that's not much, but then it's only in the initial cases when somebody is doing the cases, then you encounter such cases. Once you are like more than 10 cases into the plaques, then you don't usually have such complications. Yeah, the commonest complication which everybody encounters when it comes to a Len6 or a Victus platform is the subconjunctival hemorrhage. That is one thing we need to talk to the patient, because there are patients who are like, what happened to my eye? That is the only thing. And I think it should be covered in the preoperative counseling rather than the postoperative work.
One very common effect that we see is the pupil comes down.
Yeah.
So even after you have, if the pupil has been dilated well and you have done a femto, and when you take it up for phaco, then you can see that the pupil might have come down. That is because of the prostaglandin release. So, but which is fine. If you inject some phenocaine, the pupil comes back. It gets dilated again. Are there any rare complications that you all have seen? Anything other than, sometimes you may have a smaller pupil and has the laser hit on the iris, or any? I've had some 3 very rare complications which I would share. But first, any of you all, if you have had any?
There was a case wherein there was a very small set of bubbles which were like equally placed at the capsular margin, and we thought the capsulotomy is done, but there wasn't any capsulotomy which was done. So I mean, therein when Ritika says like you should try and bring it to the center, then we thought, what happened? Then we did a capsulotomy and then we were able to do the phaco. So yes, the incision was there, the lens fragmentation was there, but there was no capsulotomy. I don't know. When I had a talk with
had only once such
I had a talk with Alcon guys, they said, sir, I don't know what happened. But then yes, the next cases, they all went very fine.
right,
So,
right.
no idea.
This is what I suggest, in the cases of femtolaser cataract surgery, posterior cataract surgery, or routinely, where you're not using a femtolaser, or you can say dense posterior subcapsular cataracts, you have to use a technique by which you put a fluid into, can say, at the time which is not going behind. So you are just trying to put a fluid into the area where the end of the lens is there. So you may see a fluid wave, but it is not going very actively. It is not going very actively. So it is something like a equatorial hydration, where you are putting the fluid into the equator and the fluid is not passing very actively onto the posterior capsule, where it can break and cause complications. So I feel in femtosecond cataract surgery also we should maintain this. The reason being that the surgeon doesn't know how many air bubbles are there between the posterior surface of the lens and the posterior capsule.
Right, right.
So they have to keep on pressing onto the posterior onto the lens every time they face this situation.
Right.
So fluid force has to be very mild, and whenever the feasibility is there, you keep on pressing onto the nucleus so that air bubble comes out. Anytime you put any fluid very forcibly, in addition to the fluid, you have an air bubble which is going to press between the posterior capsule and the posterior surface of the lens, which can cause the posterior capsule rent. So we should be more careful about this. This is what I wanted to
Yeah.
put for,
Yeah.
put forward so that that we don't face any complication.
Right. So there's three other rare complications which I was mentioning about. One, I had a retained capsulotomy flap. So when I saw the patient the next day on slit lamp, the eye was quiet, but the capsulotomy flap was in the anterior chamber. So the similar case has been reported by the Arvind group too. The second complication I had was an intracameral bleed, which has not been reported anywhere. There was one subhyaloid hemorrhage that has been reported, but an intracameral bleed was not reported, probably because of the IOP fluctuations. Otherwise, there was no NVI or any other pre-existing problem. And the third very interesting complication was the femto was done, but before we took up the patient for phaco, the patient became breathless and she went into an acute LVF. She had to be admitted in ICU, and we had a gap of almost 2.5 months before we could take up for phaco. So this is a very interesting and a very rare situation where we cannot go ahead and do a phaco, but the capsulotomy has been done already. So even the Arvind group has reported such a situation, but they could do the surgery within a week's time or 3 to 4 days, and they had a very good outcome. But unfortunately, in my case, it was COVID times, and we had a gap of 2.5 months. By the time all the cortical material had come out into the chamber, the pressure had shot up to 50, and we could not operate. She didn't get fitness because of COVID. And we had lost the eye. In fact, after 2.5 months, I went ahead and did the surgery, but there was already optic atrophy. So in spite of doing a cataract after that, we couldn't save the eye. Another one question is, yes, if there's a phakic IOL, just for the benefit of our PG students, can you go ahead and do a flax? And what would be the challenges? Anybody would like to answer?
We can
But
do.
if there's,
Sorry,
sorry.
am I interfering? Okay. Yeah.
So
Sir,
if there's a
go ahead.
phakic IOL, I would first remove the phakic IOL. Of course, you can do a flax.
Yeah,
Why
on the
can't you do a
with
flax?
the
Yeah.
phakic in situ, can
Yeah.
you do a flax, and what would
I've
be?
never tried it. It'll be interesting to know what the laser computer thinks.
Yeah, I
Have you tried it?
Yes.
Yeah. What
So,
happens?
yes, so the two, three things. So one is the laser considers the phakic IOL as the lens. So it tries to focus there. So you have to manually
Right,
bring those
manually.
dots
Yeah.
down onto the anterior capsule. Number one.
Interesting.
Number two, when you actually take up, this was a patient of very high myopia, one diopter lens, and we had a radial tear. So apparently the gas bubbles that are accumulated between the phakic IOL and the anterior lens capsule can incite a radial tear. So you have to be extremely careful when doing this. Now this was a very high myope. Now thirdly, in this phakic IOLs now, you have to first remove the phakic IOL and then do the cataract, right? But this was a V2 model of the IPCL, which is a little more rigid compared to an ICL. So maybe I thought that you would have to extend the incision to around 3 or 3.2 millimeters instead of the 2.8. But if I would have done that, then there would be wound leak and hypotony and difficulty while doing the nucleus removal by phaco. So I decided to keep the phakic IOL and did the phaco underneath the phakic IOL. After the nucleus was removed, then removed the phakic IOL, then did the IA and then put in the IOL. But there was no need to do it. When I removed it, I found that I could have removed it even through a 2.8. So take home messages with any phakic IOL, you can remove it, then do the phaco, it will make life easier. So I learned it the hard way. So just a take home message for all the PGs. One more question.
I wanted to add for the
Yeah,
postgraduates,
yeah,
if a patient has a phakic IOL in place, it does not affect the biometry
biometry.
when
Yes.
you're doing that. And the second bit is that if you're doing a femto through viscoelastics or through phakic IOLs, when the refractive index changes, sometimes the focusing of the femto is not as precise. So definitely be careful that you may get skip areas of treatment. So whenever you are doubtful, you must use a dye, or you must kind of have the centripetal pull, because if you underestimate the skip areas and the rexus is not free floating, you will get a capsular tear. So if you're going through a phakic IOL, going through archic cuts, or you put visco, or there is silicone oil in the AC, these are all relative kind of red flags where you must be wary of skip areas.
Dr. Rahul, which is stronger, a manual CCC or a femto?
$1 million question, but I would still say a manual CCC should be stronger, ideally. But I don't think, if you don't have, even though there are skip areas, the consistency, I mean, even in the small CCCs, the IL still goes in, a large IL still goes in, and there's hardly any problem. But yes, they say the manual definitely is a bit more stronger on paper.
And we used to have the Zepto,
Consider-
and Zepto was supposed to be even stronger. There used to be videos how they showed that how it
Yeah.
doesn't tear. Anybody else have any inputs on
Considering
manual versus?
that you know that whenever any femto laser cataract surgery has been done, whichever machine you use, it's a basically online OCT which determines the structures of the eye. So we have to ignore here about whether the ICL is there or not. So you have to manually connect ICL where the antechamber is maybe a little bit shadowed, and place it onto the anterior capsule well, and you can get away very easily. So I would still say that if you have instruments, it's not mandatory. If you have instruments like you can say femtosecond laser, I think it's a boon where you can manipulate the things and do a capsulotomy in spite of ICL being there. Only issue is in this is that AC is little bit shallow. So you have a chance to manipulate it manually. Once you manually manipulate the position of the lens, then the OCT will take over. So somewhere the technology is going to work very well, and it can be done absolutely very fine.
Right. So one question to all of you. We agree that yes, it is a better technology. We are reducing the EPT, improving the visual outcomes. But if you are, everybody doesn't have access to it. So which are the specific indications in today's date where you would actually, you really believe and are convinced that it would give a advantage over routine phacoemulsification? Each one of you, one indication.
Hard brown cataracts, grade 4 cataracts, any day.
Any patient with
Virus.
any endothelial issue like early Fuchs dystrophy, all these people always tell them better do flax, and of course harder cataracts.
Correct. Dr. Ritika? You're muted, ma'am.
White cataracts, I think it's a standard of care for us because the rex is being more predictable. And we feel that the posterior polar cataract also, I mean, though
For sure.
Yeah.
can be managed better, given the fact that complications in posterior polar cataract,
Yeah. The
But-
only issue in white cataracts is, does it really cause a nuclear fragmentation? Because in brown cataracts it does, but in white cataracts for the capsulotomy it really works.
Capsulorhexis white cataracts are often
Yes.
soft, And the capsulorhexis is where you're going to have your,
Reduce the incidence of Argentinian flaccid. Yeah. Any other indication? Subluxated cataracts, I usually advise, so that you can center it on the scan capsule, as well as the risk of, the radial tear happening, and then the risk of not being able to put in a CTR also reduces. Any other specific indication, Dr. GB?
I think if you're having, let's talk about the subluxated lens. When you're talking about the subluxated lens, if you see a patient who is having a subluxation in an area where there are no zonules, you won't find that area to be, you can say, curved. It will be rounded only. So you have to preform having an opinion that what should be my rhexis and where it should be. And if you have something like a femtosecond technology, or manually also you can do it. But if you can't, if you have something like you can say femtosecond technology, then you can manually manipulate the position of the capsulotomy and you can do it. Does it work very well? It works excellently, absolutely excellent. But suppose you don't have, femtosecond technology, then you have to think priority where this capsule eventually is going to go. So you have to come a little bit away from the periphery of the rhexis margin, from where the subluxation is there. And the reason being that at that point, at that position, the capsule is more rounded than it is curved, only because zonules are not there in that region. So you have to contemplate what this rhexis is going to be there after the surgery, if the femtosecond is not there, and you can do it. And many of you, including yourself, and you can do it. There is no issue.
Right. Dr. Cyrus, what is the routine size of the capsulotomy do you keep, and do you feel the need to change it to smaller or smaller?
So my standard is 5.5 millimeters.
Okay. How about the others? Is it the same?
I would keep it as a 5.5 for a normal patients, but I will keep it as a 4 to 4.5 for a subluxated cataract. The reason being that I really don't know where it is going to go. So 4 to 4.5 would be my call for a patient who is having a subluxated cataract, which is more than 90 to 120 degree.
Okay. Which is the smallest capsulotomy you have done? Anybody?
2.5. I'm serious.
Because the people were small, or you did it?
No, people was too
purpose?
small. The structures were so small. So I did it with the femto laser, and then I extended it afterwards to say 3.5 to 4. So of course we could have used the you can say iris retractors and other things, but it was not needed. You could finish the case very well with very good results, and we have a follow-up of more than say 10 to 12 years. So they are all doing well.
In a very small pupil, has anybody, like she was saying earlier, put in a Malugan or a BX and then taken up the patient for femto?
That's a little bit different and tricky issue. The simplest thing for me is that if people is not dilating beyond 2.5 to 3 millimeter, I would simply do a retraction by using two instruments to the limbus, by which only iris, you can say, margin of the iris is going to have a crenated border. But at the end of the surgery, if you see patient on a day 2, day 3, day 4, the pupil is not going to be more than say 2 to 3 millimeter. So a simple retraction is the one which I would go for.
Yeah, Dr. Rahul, you want to say something?
Because it was a PG teaching program, so I had prepared a few things. So there would be a few questions that might be asked to the PGs. So we are talking about a 1053 wavelengths, and then you have got a 1064 wavelength also. So one is a photo disruptive, second is a photo ablative. So there has to be a difference. So what's the difference between that? So I just compiled this for the PG. So what happens in an ND YAG, that's an ND YAG we are talking about, and this is an ND glass laser. There's a very slight difference in the wavelengths, but the one it emits the length, I mean, the duration of the pulse is nanoseconds. This is femtosecond. Because it's nanosecond, the photo ablation, what happens here is there is micro cracking. Sorry, the photo disruptive, both are photo disruptive. So there is micro cracking when you're doing a ND YAG laser of surrounding surface. There is heat transfer, which is more. There is a melt zone, which is again more. And the area which it takes, it's around 100 microns. Whereas when it comes to your femtosecond laser, again, the wavelength is more or less similar, but then it's uh, using only it's utilizing only a 1 micron or even less than that, number one. So there is no micro cracking, there is no heat transfer. The reason it's so precise, that is the reason you can use it. So this is one difference which PGs might be asked. And one more interesting thing which I found, that the first FDA approved laser system was in 2000 by the name of Dodotic photolysis system. It was a Q-switched ND-arc laser, and it generated shock waves at 200 to 400 nanoseconds. But then obviously, because it was a nanosecond laser, it was far more disruptive and it had more energy being dissipated. So that is the reason it wasn't in vogue. And then it was in 2010 that the first FDA approval came for the Lens 6. So it took around 9-10 years for the slight changeover. So these are the few things I want to add on. And finally, the limitations of femto. So if at all there is any corneal opacity or corneal edema, there are posterior synechias, pure pupillary dilatation. These are the things wherein you shouldn't go ahead with. Obviously, there are people who are still doing it with pterygium and all, the opacities and all. Yes, as you master the femto, obviously you are more comfortable doing in such cases. That's what I wanted to add because it's a PG teaching program.
And the high cost.
I
The
mean,
teachers
so
should
Dodic,
know about
Dodic India
additional.
laser was, am I on the line?
Yes, we can hear
Yes,
you.
sir.
The Dodic femtosecond, or you can say India laser for a cataract surgery, was first submitted in 1987. It got FDA approval quite late, but it never progressed because India laser is never a good strategy as far as the nucleus of the cataract surgery is concerned. So why did not, when in 1987, when Dodic laser was produced and it came commercially outside, why did not it progress? Because it did not have that credibility as far as the nucleus division is concerned. So what we are talking is Dodic laser in 1987,
Yeah.
never progressed to a bit, a particular length. So we are stuck up with something what is called as we can say ultrasound modulation into the you can say ultrasound technology in such a way that you create a result as good as a cold laser, or you can say without creating any energy or heat. At the same time, you can get a quiet eye. So that's the reason I feel personally. And that's the reason Dodic laser never progressed to from 1987 to beyond a particular limit, though it was commercially available everywhere, but it never reached to the level which it should have been.
Sir, it was just an interesting question because if the external is asking
Yeah.
you questions, he might ask, which was the first FDA approved laser? So everybody would say 2010 Lens 6. No, 2000, there was a laser which was already approved. Obviously, it didn't work. It's just for the PG, sir. Academic interest.
Nice.
I understand. I agree with you.
So, any other inputs?
You're muted.
We wind up? Dr. Cyrus, you're
Saying
muted.
something.
Sorry?
We
Dr.
can't
Cyrus,
hear you, Dr.
Cyrus, we can't hear you.
You're
Cyrus,
muted.
we
You're
can't hear you.
muted.
Yeah. So the Dodic laser used to hit a metal plate and that used to vibrate. But
Yeah.
it really was awful. And I don't think there were any in India. I don't think anybody bought one. In fact, Dr. Kelkar had bought one laser a long time ago. And that was like a direct laser beam. hitting the cataract, but that wasn't really very effective. That was probably in early 90s. That was probably the first cataract laser that came along it was in Pune. I don't think
It
any
was
of the
not only
externals
in
have ever
Pune.
seen a
It
Dodic
was
laser
bought
except
by
from
Dr.
a
Mukadam.
textbook.
It was also bought by Dr. Mukadam
Okay,
in
that's
Nagpur,
interesting. All right.
Dr. Kelkar in Pune,
Yeah,
one more person in Pune, and there was one
yeah.
more person who was there somewhere else into Madhya Pradesh, but it never worked.
It never worked. Yeah.
Why didn't it work? The only reason why didn't it work because you didn't have any methodology to break the nucleus into multiple pieces. It created too much of a energy. It created too much of a inflammation, and it didn't work.
I
That's
have a
the
question for Ritika. Ritika, I'm seeing lots of reels that AI is doing cataract surgery now. Is there any actual role of artificial intelligence in cataract surgery, or are we still using the doctor's intelligence only?
So I think that because it's a buzzword, the role of AI is in how you communicate to the patient, and it's basically being used to market it to the patient because the patient doesn't understand femtosecond laser. And actually, the irony is when phacoemulsification came in, people couldn't pronounce phacoemulsification, so people used to say laser surgery kar raha hai, right? So that is the truth. So the phaco became laser, so laser had to become something else. And this actually is the peril of substitution gone wrong. And therefore, that's what I mentioned, that the femtosecond laser is often referred to as AI or robotic because laser was often jargon for phaco. So that is the irony of the scientific mismatch of terms between science and market.
Yeah, this we can say as far as the perception of a layman is concerned. We are talking today about the science.
Yes, sir.
I'm sorry to say that. When we are talking about the science, we already know that what he did about the as far as the phacoemulsion is concerned, which is nothing but advancement from the dental piece of work
Yes, sir.
into ophthalmology, Dr. Kelman, and it's a big thing. That thing progressed into multiple things that how you can use ultrasound as a cold energy, like a laser surgery. So that's why all these, you can say, multiburst, you can say hyperpulse, and all this came into the play only because we are trying to play. We are trying to bring into phacoemulsion or ultrasound into an array of a laser type of energy. That's why all these modifications came into. Eventually, okay, in spite of doing all that, the laser came in, which is in fame of, you can say, phantom laser. And you all know that it's working very well. But for a layman's perspective, anything can happen. You can say that even SICS is as good as a laser because we are not taking any stitches. You can say that you are doing a phaco and it is as good as a laser. That limitation we cannot decide because we are not authority into it. It is a layman's understanding about our procedure, the way we project it.
So my humble submission to postgraduates would be, as doctors, it is our responsibility to spread the right kind of knowledge.
Oh.
And we should take some degree of ownership into what the layman is processing. And societies like the IOS and us as individual ophthalmologists should contribute to it in a positive manner rather than a negative manner.
I absolutely agree with you.
One more thing I want to add, because 10 years, 15 years down back, you had limited access to the social media. Now, anything you say, I mean, by the time you realize the relatives and all have already Googled the thing, and most of them, they come all prepared. So if you speak the truth, it's much better. I mean, be it the lenses, be it the type of laser you're using, be it the type of phacoemulsification machine you're using, because somebody in your city is actually highlighting a procedure or highlighting a machine doesn't mean that is the only machine. So yeah, obviously, as what Dr. Ritika said, it is the duty of all the members of the AIOS and specifically the PGs who are actually going to come up with these new technologies. And these technologies are going to change very fast now. I mean, gone are the days when the new machine used to come after 7, 8, 10 years now. Every three, because of the AI. I think, Cyrus, the AI is going to help. Maybe by 26, 27, we'll have the AI integrated more into ophthalmology.
Yeah, probably the AI will decide what lens power to put in better than what we can guess, with especially odd cases like after LASIK and bad RK corneas or post-keratoconic corneas, what IOL power to put in the eye. Maybe AI will be smarter at deciding lens power calculation, but is AI going to do the surgery? I don't think so for like at least 15, 20 years.
I wouldn't recommend.
Too many variables, it's not a car door that it can be held and the robot will do different welds. That like the robots make all the cars today. So operating the eye or the heart or whatever is totally different.
I wouldn't give my eye to a robot. I would definitely want a
Not for 10, 15 years at least.
I would never. I would never.
Yeah.
No,
Yeah,
on the name. So to come to a practical point, as far as the robot concern is not. See, today we have a lot many formulas which are depending upon the AI, that is artificial intelligence, and the main you can say stay of that is depending upon what is the basic value, that is the keratometry, axial length, and antechamber depth in this patient.
I think
Then
this is
they are
where
going to work.
AI is
No,
going to
then they are going to work. Okay, what is AI? As far as the Hill RBS is concerned, they are going to consider each value as a considering that key, what it is going to produce a value which is related to that particular keratometry. Now, if you go beyond a particular limit, it's not going to work. It may be working for them, fair enough, and I'm really glad. Let's take an example of RK. Now, Arcadian, which is in Russia, RK, which is in America, RK, which is done in India, and any part of the world, you can have n number of variables for that. And we have to come to a simple calculation. What is the present level of a keratometry in that patient and why this has happened? That will give us answer. Thank you.
Are we done?
Yeah, I think it.
Yeah.
Most
So
of the
it was great to listen to everyone today, and thanks for having me here
Same
and for asking for my limited inputs. And so I think femtosecond laser cataract surgery is not going to go anywhere, and eventually, in some form or the other, everyone's going to end up doing it. The cost is an issue, so that's always going to be an issue in a country where a lot of people just don't have the finances to pay for it.
and great.
Doctors and patients. Yeah. Okay.
Yeah, so sorry, I had some patients. Thank you,
Yeah.
everyone, Dr. Ritika, for such a lovely presentation. Dr. Cyrus, Dr. Jeevan, Dr. Rahul, for sparing your valuable time. Thank you, Dr.
Bye.
Prashant,
Thank
the
you.
AIS
Thank you,
president.
Rahul. Bye,
Thank you.
Jeevan. Thank
Thank
you,
you.
Anagha.
Okay, bye,
Bye,
man.
Ritika.
Bye.
Bye. Bye.
Thanks a lot.